Hello, everyone, and welcome. My name is Meena Dayak. I am the Executive Vice President for Market Intelligence at Open Minds. I will serve as the moderator for today's web briefing. I know that many of you have had to significantly change the way you deliver services and operate to adjust to the new normal created by COVID-19. So we at Open Minds are here to help you with our new executive blueprint for crisis management, building organizational sustainability and success in a disrupted health and human service market. And through this program, we are providing on-demand resources and technical assistance to help specialty provider organizations like yours navigate a market in turbulence. Today's web briefing will be led by Open Minds Senior Associate Deb Adler, who you see on camera. This is the third briefing in our Blueprint series today. And joining Deb today are three leaders from provider organizations. We have Jen Dorsey, George Colodner, and Diego Garza. And Deb is going to tell you a little bit more about each of them shortly. But all four people that you see today on our briefing will be sharing their on-the-ground experiences and talking about developing the consumer and staff training guidelines needed to quickly expand your telehealth services. So just to tell you a little bit about Deb, she has more than 20 years of experience in executive roles in healthcare. Deb is the former Senior Vice President of Network Strategy for Optum, where she was responsible for behavioral health network development, contracting, and strategy for more than 185,000 providers. In this role, she developed the largest performance-tiered behavioral health network, telemental health network, and medication-assisted treatment network. Deb Adler is also a certified professional in healthcare quality. And before I hand it off to Deb to introduce our other speakers and to dive into today's briefing, just a couple of housekeeping reminders. Your audio is muted throughout today's web briefing, but we welcome everyone's questions and comments. Just look at the question box on the right of your screen, and at any time during the briefing, you can just type your question and send it in. We will ask the people to answer these questions as they are speaking or right after their presentations are over. And also the slide deck and the recording from today's web briefing will be available on the Open Minds website shortly, probably by the end of day today, and we will send out a link so that you can have access to it at your convenience. So thank you all for joining us today. I know it is a very busy time for everyone, and I so appreciate all of our speakers making the time to share their experience. I know we will benefit from it greatly. With that, it's over to you, Deb.
Thank you, Meena. I'm delighted, and I echo the welcome to everyone to our webinar today. As Meena noted, this is the third in a 32-week program that Open Minds is sponsoring on providing a blueprint for crisis management. I want to tell you just a little bit more about my panelists today. I have two individuals from Colmac Outpatient Recovery Centers. They operate 9 clinics in 3 states, Maryland, DC, Pennsylvania, and soon we'll be adding Virginia. Jen Dorsey is the Chief Clinical Officer and Vice President of Operations at Colmac Outpatient Recovery, and she's a licensed professional counselor and certified addiction counselor. And I'm really looking forward to having her share her experience in helping pivot very quickly within 24 hours to being a fully virtual program and her experience with providing guidance to both staff and consumers. I'm also thrilled to introduce George Colodner, a psychiatrist who is really what I would consider the pioneer in establishing the first intensive outpatient addiction treatment program in the country. He has over 40 years experience serving individuals in the Maryland, DC area. He's not only served as a clinical professor of psychiatry at both the University of Medicine and Georgetown University. He was the lead author on Withdrawal Management Chapter for ASAM, which he'll tell us a little bit today about how he's introduced virtual withdrawal management into Colmac's program. And then last but not least, Diego Garza, who is a physician and also the Vice President of Strategy and Innovation and Director of Telehealth at MindPath Care Centers. MindPath is a large outpatient practice, over 150 providers offering statewide services in North Carolina. I think it's really remarkable as well that Diego has been the director of telemedicine there since 2017. So I don't know that too many outpatient practices can claim to even have a director of telemedicine and to have that in place for that length of time. He's won a variety of awards, including the North Carolina Care Hero 2018 award for his support of healthcare professionals and commitment to increasing quality services to the North Carolina population. So I think we have an excellent panel today. So with that, I want to dive right into the agenda, and we will be watching for your questions and covering them towards the end of the program. I'm going to talk just for a little bit about why telehealth guidelines are so important. I think it's obvious in this period of social distancing and our absolute demand to move to virtual services. So I'll talk about why you need guidelines for both staff and your consumers to make sure this is an effective approach. We'll talk a little bit about the payer response to the pandemic crisis, give you some guidance there. But most of the time I'll cede to our two case studies that we're offering today. Colmac Outpatient Recovery Centers transition to virtual, and MindPath's transition as well. And all of our panelists will speak to lessons learned. So with that, let's talk about why you need guidelines. I think, not every provider is able to quickly translate their skills to this type of medium. So I think guidelines are going to be very important, particularly as we've been rapidly plummeted into this new environment where, if you want to sustain your practice, whether that's an outpatient, IOP, partial program, any level of care, if you want to sustain your practice, you have to come up with ways to deliver services in a virtual manner. We are going through a period of time where there has been some loosening of the regulatory restrictions. For example, the Office of Civil Rights has introduced the ability to use non-HIPAA-secure equipment as a potential, but I think we all need to be prepared on how that will shift and turn post-COVID. And I'll also be sharing with you changes that payers are making to respond to this pandemic, in particular waiving copays and cost shares for their members. I think while many organizations, I know when I have done Open Minds panels in the past that are live forums where we have 500 to 600 individuals, whenever I ask people to raise their hands if they're doing telehealth, I would say 90% of the audience raises their hand that they are doing some portion of their practice telehealth, but now there's that intense pressure to pivot completely to a telehealth modality. So you need to be well aware of the payer requirements, the regulatory requirements, and I would say the consumer's readiness to adopt, as well as the training of staff so that they can adopt these new practices. I know prior to COVID, it was pretty common that in the payer space, where I've spent most of my career, that you might at most see 1% of the outpatient sessions delivered through telehealth. And we're now experiencing a rapid increase in that adoption rate. And I'm very curious what will happen post-COVID. My personal opinion is it's going to be hard to put that cat back in the bag, and that there'll be a continued demand by consumers to be able to have the ability to access services virtually. So with that, let me talk a little bit about what we're seeing being developed. And I know from working closely with Colmac Outpatient Recovery, I was very impressed with the guidelines that Jen was able to quickly ramp up for her staff. And I think that's critical because it's not easy to modify your face-to-face clinical skills and bring them into the virtual world. I used to joke that I would probably be the worst clinician at delivering virtual services because I would say up until a few weeks ago, usually when I was on Zoom, it looked something like that rather than the appropriate mechanism for even keeping your head in the screen, if you will. So I think it's really important to offer training so that the providers within your practice are aware of the steps they need to take to assure privacy and security and effectiveness of the treatment. I think the same goes for consumers. Many consumers had telehealth as a benefit prior to COVID, but very few used it. I think largely because there was a lack of awareness and understanding that it was a covered benefit. So this is a great time to help educate consumers on how they can access these services and what they need to do to assure privacy and security and effectiveness of the treatment. Let me just spend a minute talking about what payers are offering during this crisis. And I would definitely recommend that you continue to monitor for your payer mix, the websites and provider portals where this information is publicly available. Many of the payers are waiving cost share for in-network services for behavioral health televisits, and they do not have to necessarily have any relationship to the actual diagnosis, if you will, of the coronavirus. That's not true across the board. So again, you need to check with each payer. Many are making those waivers continue into May and some into June. Others are recognizing that while live video is preferred through a HIPAA-secure modality, in a pinch, telephonic visits can be offered if it's medically appropriate to do so. And all are requesting that you use the specific codes that they've outlined for telehealth. We'll talk about those. So if you go to the next slide, this just gives you an example of 3 national payers, Aetna, Cigna, and Optum, and 1 Blues plan in the Maryland, DC market. Aetna, I think, has done a great job of being very explicit with which codes are they allowing copay waivers. So I think that they've done a nice job of being very detailed and providing you information on the effective dates. Cigna, the last I checked, which was last week, they are not offering cost share waivers for mental health telehealth visits. Optum is, and they are very explicit about their time frame until June 18th and in which situations it applies. And again, I'm not going to go through all of these, but I just want to give you a flavor of what the payers are doing. So let's go to the next slide. This gives you a picture of, again, the codes. Most of the payers are asking that you use the place of service code 2 to signify telehealth, or in some cases using a modifier like the GT modifier or modifier 95. But again, I would always recommend that you look at your contract with the payers to make sure that your contract references this. Again, many of the payers right now are waiving certain requirements for telehealth. For example, many payers require that you do an attestation to signify that you're using HIPAA-secure equipment. That's largely being waived during this time, but once we get back post-COVID, I would make sure that you've turned in the appropriate paperwork and attestations to use telehealth. And then last on the next slide, again, this gives you a little more specificity around payers' guidelines on whether they're allowing audio only billing, or if the preference is towards real-time live audio video conference calls, if you will. Again, check with your payer to make sure you're complying. With that, I want to pass it over to Jen, who's going to tell you a little bit about her experience at Colmac. So Jen.
Hi, everyone. I see my webcam is coming up. It's great to be here with all of you this afternoon. Quick thank you to Deb and Open Minds for inviting me on behalf of Colmac to tell you a little bit about what it's been like for us in the last month. And really, Colmac is a great representative of an organization that 1 month ago on March 13th, that was a Friday the 13th, you all may remember that, we had about 5 to 7% of our services that were viewed via telehealth or virtual. For the last 46 plus years, our services have all been on site in the physical space with our patients. So that was, we've had a huge shift to 100% services via telehealth at this point. So I'm going to tell you a little bit about that in a short time to do that. So I'm going to be quick and to the point, but also happy to answer questions later on. So in kind of a background of Colmac, as Deb said, we started in 1973 by Dr. Klodner, who you're going to hear from in a bit. And at that time, it was the first IOP in the country. Our focus since that time has really been on providing outpatient services to adults with substance use disorders and co-occurring psychiatric disorders. And our current levels of care are intense outpatient withdrawal management, or detox, also known as detox, intensive outpatient, what we call continuing care, which is long-term outpatient groups. We've added individual therapy, and then kind of supporting that through all of our services. We have family groups, we have MAT or medication-assisted treatment services, we have co-occurring support for our patients through psychiatric staff, and again, that's through all of our services. So we have a really robust outpatient model, and we serve about 1,400 patients, have 250 staff members, and as Deb said, we were operating in 9 physical locations throughout Maryland, DC, and Pennsylvania. We were using telehealth as of March 13th, and Dr. Klodner can talk a little bit about this from our medical perspective in terms of warm handoffs between our medical staff providing detox to our clinicians. And the other way we were using telehealth was through our leadership and our business meetings. It's hard because we're spread out over our 9 offices to get around to those offices. So we were using, in our case, Zoom to connect with our patients. And a note on EMR, we really still, at that point, March 13th, I would describe our EMR platform as 50% electronic, and 50% we were still operating in paper. So we really still have had a strong connection to that pen to paper, sitting in person with our patients. And you can go on through to slide 14. And so what happened was on Saturday, March 14th, I was sitting at home. It was about 9 o'clock at night, and I got a call from our on-call clinician who said that one of our patients called and reported that she had tested positive for COVID. And of course, that kicked off a flurry of activity for us in terms of closing that office. Patients and staff had to quarantine for 2 weeks, and I'll just add quickly that everyone is healthy and recovered, and we're really grateful for that. That Monday morning, we came into the office and had a discussion about the safety of our patients and staff, and made the decision that we could no longer safely operate in our physical spaces, and decided to transition to virtual operations. And we were able to, kind of the punchline, the end of the story is that we were fully operational for all of our services starting on that next day in the evening for our evening groups, so Tuesday, March 16th. And so the question is, how did we do that? It's all a bit of a blur because it's and intense, as I'm sure a lot of people experience, but it sort of broke down what I think were the most important steps that we took. So first and foremost, I think it started with an attitude that was shared by leadership and really the entire field. And the idea was, one, that we could do this virtually, that kind of belief. We had been thinking and talking about the future of Colmac and could we provide these services, outpatient groups in a virtual setting. And so we'd already kind of had our minds starting to think about that. And I think the next piece for us with COVID was the most important thing is that we stay connected to our patients. Because when it comes to substance use disorders, the idea of having to stay at home, socially distanced, not able to get anywhere, losing that accountability, we knew for most of the people that we treat would be a really serious issue. So that was the other piece. It was this mindset of, we can do this, we can provide quality, effective treatment through telehealth, and we have no choice but to do this, because if we don't, we will lose patients, literally lose patients. So the first step we took was to put together a really security features to do investigations through Zoom. Even though we already had a HIPAA compliant platform, and before Zoom bombing, that word was inserted into our lives, we really wanted to make sure that we prevented what we thought would be accidental exposures and risks in terms of patient confidentiality and privacy. So some of the things that we put in place are requiring our patients to register for their groups. They have to register with their first name. That really allows the clinicians to approve the registration before they get a link to join the group. We require waiting rooms for all of our groups so that even if you get a link, in order to actually get into the group, the clinician has to approve you. So those were just some of the security features we decided to put in place right away. From there, we created very quickly, as you can imagine, Monday morning until Tuesday evening, created written instructions for our patients and for our staff on how to join and create virtual groups through Zoom. We also added in guidelines for the staff and for the patients in terms of participating in virtual groups. Now, we were doing that without really having any experience, so a lot of that has shifted, and I think that's one of the things that we're all keeping in mind, is that we have to allow ourselves the space to kind of create new ideas every day, because we're learning new things every day, which I think will be echoed by Dr. Garza, as you'll hear. And then we also needed to add in these consents to participate virtually and also to email our patients, because we have never emailed our patients. We were that sort of centered on being in person and connecting with them. So we had very quickly these instructions, these guidelines, consents, communication with all of our staff and all of our patients. And then very quickly, we kicked off with the intense training. So it was a quick expansion of our IT department. And we went from a very formal IT department with formal training to people like me who, and a few others who don't have formal training, but maybe had a little more comfort level with the platform. And we provided that IT support for our patients and our staff to kind of problem solve as we go along. So that was kind of our first phase of implementation, was connecting, training, problem solving. And of course, part of that problem solving was, what if our patients could not connect to Zoom, they couldn't figure it out, or they didn't have the technology to do so? And so just quickly, how we've approached that has been, who are people in the household that with patient consent, we can get them to help us try to work with that patient to get them connected to Zoom. Next is that we made the decision to purchase and send tablets to patients who did not have access to that kind of technology. They just didn't have a computer or their phone wasn't set up for that. And then the other option is for us to use telephone therapy. So our next phase was really support. What was going on in the background at that time was switching over our website, reaching out to all of our massive provider network to let everybody know that, hey, we're here. COMAC is able to work with you for all of our services on an ongoing basis in a virtual platform. And the other thing we did was we reached out to former patients. And I think that's a really important piece because we had people who came to us and either stopped doing treatment because they, their jobs wouldn't fit with that hours, or maybe they weren't ready at that time, didn't feel like they could make the physical commitment of leaving work and getting to treatment. And obviously things changed for a lot of people. So we reached out to our former patients. And so communicating to the world was our next big step. Phase 3 was focusing on some of the details. I think we gave ourselves permission to do the most important thing first, which was stay connected to our patients and do everything we possibly could to make sure that every single patient transitioned over to virtual. The result of that is 85% of our patients transitioned, which given the 24-hour turnaround, to me is just incredible. But once we got through that first really heavy week of all of our groups getting through at least one time, we really started to focus on some of those details that came after that. So things like a virtual patient handbook, which we only had in a paper version that we could hardly even find an electronic version of, creating standard operating procedures for virtual groups. We added technology for how our patients, instead of just emailing forms, could actually sign those forms electronically. Guidelines for clinical operation of groups, but also how do you do things like, what are the appropriate limits to set in groups? We never had to worry about patients smoking in our groups, but all of a sudden we've invaded their households and they're laying in bed, comfy in their PJs, smoking a cigarette. And how much of that do we say you can't do that? So we're still learning about that. How do we do urine screens and blood work with our patients who are now not coming to the site? So we had lots of details that we had to figure out, and that was sort of our third phase. And I think the phase that we're in now is really, is hammering these things down and becoming experts. And so that's a process. We are not there yet, but we're really, really working on it. So I think that covered the next couple of slides. Thank you all. So our thoughts about, because in the midst of all of this, we've been thinking about, well, what happens? And like Deb, I really believe that not just the addiction treatment field, but the recovery community at large will be changed. We've seen tremendous positive responses from our patients in regards to moving to virtual. They were shocked by how quickly we did it. I think as were we. Grateful to have the connection. We've heard a lot of feedback about people feel like it's even more intimate than it was previously, which is pretty incredible. But we've learned a lot, and you're going to hear a little bit more about that from all three of the presenters. But I think for us, what we're really imagining as far as the future goes is how do we now reach patients who we couldn't reach before because of our geographic limitations. So the ability to help and provide quality treatment to people in parts of Maryland, Virginia, and Pennsylvania that we couldn't reach before because we don't have a physical site. We've always been limited to operating Monday through Friday. We've started to we added actually just in the last couple of weeks a Saturday group. Weekends in a lot of ways have disappeared for people, but I still think there's a lull that happens on Saturdays and Sundays. And so we've added a group on Saturdays, but plan to expand to have services 7 days a week. We are experimenting with, and I think I'll just pause there and say experimentation is a really important I think, mindset that we have. We have to be cautious about our experimentation and not throw caution to the wind, but we are open to trying new things. I think we have to be in this new world that is new for us. So a great example is working with inpatient programs when they have folks that they're discharging. That for us has always been one of the riskiest time for patients, is leaving a higher level of care and then coming to IOP. And so we've actually started having folks who are inpatient start attending our IOP in their last few days of residential treatment, so that they can build a connection to the group and the clinician before they leave their inpatient program. We're hoping to expand our groups to reach more specific populations. Recorded education sessions, so those are not therapy sessions, that's just clinician talking. To be able to take our experts in that area who previously were really limited to the site where they work and be able to share those wonderful presentations and educations across COMAC. You'll hear Dr. Klodner talk a little bit more about patients who no longer need the ongoing group support, but really still need the medication-assisted treatment portion, and how we can continue to serve those folks. And we're in the middle of expanding individual therapy across all of our sites. So some of these we're checking off as we're going, and that list of our plans keeps growing and growing. The last thing I'll add before I turn it over to Dr. Klodner is that the feedback from the staff has been, I think, a reflection of what a lot of employees are experiencing, which is, not only am I having to deal with my own personal family worries, fears, financial insecurities, health, but I'm also kind of being the container for that for our patients who have those same fears and worries, while simultaneously I'm invading their homes, they're invading mine. So our staff have been incredible, but also have had an increase in stress level. And so for us, we've decided to implement a self-care initiative, providing daily periods of time where they can stop working and focus on learning skills to take care of themselves. You'd be amazed how clinicians are, as an example, not the best at stopping and taking care of themselves. So we really feel like that's an important service to provide to them. So I'm going to go ahead and turn it over to Dr. Klodner at this point.
Thank you, Jen. I have about 10 minutes. I'm going to go through 4 slides. Let me see if my picture comes up. And rather than go through my slides, I'm going to sort of talk around the slides. This first slide is the pre-COVID slide. This is something that took us 40 years to evolve, and that in which we found that we could manage many of the people who were narrowly hospitalized for withdrawal management. We could manage them in an outpatient setting by providing a structure in which they could stay all day. And the primary advantage of this was a much better follow through after withdrawal management than would be traditionally the case if people had been managed in hospitals. Our transition to follow-up treatment was in the area of 85%. And just to give you, by way of context, a sense of how we would do this, somebody would call us typically in the afternoon, and we would tell them to stop using that evening. We would see them the first thing in the morning when they would be in early withdrawal. This would be in our physical sites. We had 9 sites, and 2 of these had full-time nurses who would see the patients, medicate them with our supply of medication under the supervision of an MD or a psychiatric NP. While we were medicating them, the protocols were so good that people would sit in group at the same time. And then by the end of the day, we would give them bedtime medication, which again, we would give them a small supply of our own, and then bring them back the next day, where they would generally only need about 3 hours with medical supervision, as opposed to being there all day long. And that's the way we previously were operating. And if you go to the next slide, this is just a summary from the ASAM criteria withdrawal management chapter, in which what we did was to add a fourth level of severity. Instead of just mild, moderate, and severe, we added what we called significant to identify those people who would traditionally be treated in a residential setting, who in fact we could manage in an intensive outpatient setting. Next slide. So this is the new world that I wanted to talk about. We're now 4 weeks into this. And just to describe what we do now, when someone calls our intake center, if the intake person thinks that withdrawal management might be required, they'll call our withdrawal management nurse and transfer the patient, or have the nurse. Actually, we can do a transfer now, which was just technologically superior. Patch the nurse and the patient together. The nurse will then do a more clinically oriented evaluation and make the decision about whether this patient was someone who we could do on a virtual basis. Unlike the past time when we could only start in the morning, we could now start almost at any hour of the day. So for example, if somebody called at 3 in the afternoon and they were already in withdrawal, we could make the decision to begin their treatment immediately. So right away, we've learned that this new approach allows us to expand the window of when we can see folks. Since we couldn't see them in person, rather than dispense our own medication, we now call in a prescription to the pharmacy. But before we do that, one of the things we've learned is it's critical to have somebody responsible who can take responsibility for the medication. And we need to have a direct contact with that third party. We try to have a video contact immediately, because the kind of relationship you can form and the kind of assessment you can do is much better if you have a video component than if you're just doing it on the phone. We want to make sure that that responsible party not only will follow our directions, but that they can stand up against the kind of pressures that the patients will put them under when the patient decides that they don't want to follow, say, my instructions. So at that point, we prescribe the medication. Either the patient or the medication manager goes and picks it up, and then we begin the same kind of self-administration, but with an hourly supervision that we had in our other setting. And what we learned is those first 4 to 5 hours of medication are really critical, where since we use a front-loaded, very aggressive protocol, we really need to check with the patient every hour and see what effect that medication dose has had on them, because some people settle down quite well with 1 or 2 doses, but other people might need 4 or 5 or 6 doses. And then the other thing that we require is that everyone agree to participate in ongoing psychosocial treatment. For the most part, with us, that's our intensive outpatient program. But some where that really hasn't been feasible, we've agreed to let them go into our new level 1 non-intensive outpatient program. Just to speak about a couple of lessons learned, I'm impressed. I guess I shouldn't be surprised, but I'm finding, before we go to outcomes, go back to the other slide still, that the same amount of medication that used to get my patients comfortable is not sufficient to get them comfortable now. And it's teaching me that there's something about being in the physical presence of my patients that had some effect in reducing their withdrawal symptoms. Now I need to give them higher doses of medication. The other thing I'm finding is if I try to achieve the same level of comfort, I run into the potential of overdosing them, not in a fatal sense, but in terms of making them too sedated. And so I've had to tell my patients that they're going to have to tolerate a little bit of discomfort because in this venue I can't make them as comfortable as I would like to have. Some of the other things that we're learning is that in the past, the pharmacists are accustomed to outpatient protocols. what we're using is an inpatient protocol. So now that I phone in the prescription rather than having my own supply, if I tell the pharmacist the directions for how I'm going to use these medications, they get very anxious. Sometimes they refuse to fill the prescription. Sometimes they fill it and tell the patient that the doctor is giving them too much medication because they just don't understand the levels of tolerance. Because we have to sometimes use within a 12-hour period, we have to use as many as 300 milligrams of Librium, which seems unreasonable in an outpatient setting, but that's not unreasonable for people an alcoholic who's in withdrawal. So that's one of the other things that we're learning. Now we can go to the next slide, which is, this was actually, we now have 4 weeks. We've had 37 patients, but the rates are about the same. We have a very high transition rate to IOP. Of the 37 that we've treated, about 33 transitioned to IOP. And even 4 weeks later, most of these people are still in treatment. We've had to hospitalize. Last night, I had to hospitalize a second patient. So let me stop there, and later I'll be glad to answer questions about specifics. At this point, I'll turn over things to Dr. Garza.
Thank you, Dr. Colliner. Hello, everyone. My name is Dr. Diego Garza. I'm the Vice President of Australian Innovation for MindPath Care Centers and the Director of Telemedicine, and I'm here to discuss a little bit of our implementations efforts during COVID-19. Can we move to the next slide, please? So for those of you who do not know MindPath Care Centers, MindPath is the largest outpatient behavioral health practice in the state of North Carolina, with over 180 clinicians in more than 20 locations. As Deb mentioned in the beginning, we started this telemedicine program back in early 2017. So we have experience with it, and I personally have been developing and implementing telemedicine programs since 2008. So I have plenty of experience with that. MindPath, as you guys can see, we have an evidence-based approach. We do therapy, medication, and substance use treatment, as well as TMS and neuropsychiatry testing. MindPath has been pushing really hard for the integration of primary care and behavioral health, as we understand that those two specialties working together is the best way to help our shared patient population. MindPath has a centralized scheduling system with a fully staffed call center. So we are all about access and trying to increase that for our communities, which plays really well with our payer population. We're in with all of the public and private payers as well. So now, if we move to the next slide, I'm going to tell you a little bit about how the program looked like in 2019, pre-COVID-19. So in 2019, the telemedicine program completed almost 14,000 visits with 78 active providers. In the entire 2019, we completed the maximum amount of patients that we saw in one day was 110, which is a lot of patients. So we started in 2017 doing 30 visits per month with 5 providers, and then in 2019 we grow it to what you guys are looking at this on the screen right now. So we have made a huge improvement in what it looked like, but the global pandemic situation forced us to pull the trigger in less than 24 hours. We had to make telemedicine available for everyone. So now, in the next slide, this is how it looks like for us. So up until the point that I made the slides, which was at some point last week, we had completed almost 12,000 visits, which is pretty close to what we did in the entire 2019. I checked yesterday, we have completed more than 16,000 visits this year. So we're already way above what we used to do. On 2019, on any given month, it was 10% of our total visit volume. In 2020, it's now between 85 and 95% of our weekly visit volume what we're conducting through telemedicine. We had to, from one day to the other, we had to make it available for every provider and every patient. So we installed some group training sessions for providers as well for staff members, and that brought us to 154 active clinicians. And now our maximum amount of patients per day that we've seen in 2020, when I created the slides, was 769. Now is 924 patients in a day that we've seen through telemedicine. So it was a very interesting process for us to go through. Although we were pretty much, we had the bases, all of our bases covered. We had a training manual, we had a training protocol, we have clinical guidelines, we have staff guidelines, we have patient guidelines. All of that was already in place. We just were slowly phasing into it to get it to be a bigger chunk of our volume in any given month. This situation forced us to just do it from one day to the other. The platform that we use is called MEND, M-E-N-D, and they work with us. It's a HIPAA compliant platform that we've used since we started this program. So they really work together with us to make that available. We normally work up until this point. We worked on two models, which is schedule appointments. So you will schedule your regular appointment as if you would for an office setting, and then you will get seen at that time and date through our platform, or on demand, but it was patient initiated. The novelty piece about this, and that patient initiated response, it's called the virtual waiting room, which allows us to, the patient goes into our website, they can go into a virtual waiting room after answering some questions, and then my providers, whoever is available, and is able to see that patient based on diagnosis, symptoms, insurance, and we have a full complete guidelines for that. They can just pick that patient up. Is to mimicking a walk-in clinic. But the real new piece that we had to launch given this pandemic was the provider-initiated sessions. So now all of my providers have the ability to log into the platform, send the patient a link to their phone or to their email, which then the patient just has to click on the email and they connect with the provider right away. So now I'm going to move on and share with you some of the things that I think are very important when you are going to start thinking about moving to telehealth or increasing your telehealth capabilities. So I divided this in three different sections: policies and procedures, regulatory framework, and training. Let's start with the policies and procedures piece. So the first bullet point, it says define standard of care. For this, we should remember that the standard of care through telemedicine is the same standard of care as in office. So make sure that your providers and staff members understand what that means in terms of your own practice, and find a way to adjust those processes and procedures to make sure that it's actually happening. Second bullet point, define your scope of practice. Depending on your specialty and qualifications, this is going to look different. The scope of practice might be the same or sometimes a bit smaller through telemedicine than what it is in the office. Nurse practitioners, physician assistants, medical doctors, and therapists, they need to make sure that they understand what is it that they're allowed to do and what they're not allowed to do. Prescription patterns is something that's very important because it's regulated, and those are different by state. So you want to make sure you know those regulations pretty well. One other thing, that if you are forced to decrease your scope of practice given that this new way of delivering medical services, my advice is for you to make sure you make special accommodations for those patients that all of a sudden you're not able to keep seeing. So workflow and processes, this is one of the main rules, and everywhere you read about telemedicine, for a program to be successful, the goal is to make it integrate into our daily workflow as much as we can. That is obviously easier said than done, but it is important to try and understand from the very beginning or these early stages how this new process is going to impact the labor distribution down the road in our practice, and make it work in a way that is going to increase utilization rates of these types of services. The next bullet point is know your patient population. This is also one of the main goals when trying to develop your program, is understand who you are going to be serving. The telemedicine implementation program is going to look very different for different populations. So let me give you an example. If you work, for example, with young adults or adolescents, the program utilization rates might be higher than when you're comparing it to a geriatric population, right? Same when you think about rural versus urban areas. connectivity is directly related to the ability of utilizing these services. So make sure you understand who you're going to be treating, and then the important piece is to be able to tailor the program as much as you can to serve the patient population that you treat regularly. The next piece is define which services are going to be delivered. This is a decision that needs to be made, and you have to consider both your practice capabilities and the regulatory framework. Understand what the different regulatory bodies allow for you to deliver through telemedicine, and make that the offering to your patient population. But it has you need to understand the landscape and then make that the offering. The next piece, which is super important, is a crisis management piece. When thinking about the services to be delivered and the prior bullet point, the know your patient population point, I want you to think about what sort of crisis can I face when treating this particular patient population, right? So as a rule, in my years of developing and implementing telemedicine programs, I like to divide crises in two different types. The first one is the physical health crisis, and the second one is a mental health crisis, given the nature of what we do at MindPath Care Centers. But make sure providers and staff members are aware of the protocols, have written guidelines where you tell them step by step what they need to do. I can assure you that dealing with a crisis is very different when you're doing it online, because you are losing control of their environment versus having them in the office where you control the four walls pretty much. So think about that and put it in paper. And I mean, you're going to have to deviate from it anyway, because every patient is different. But if you're able to give them a general framework, that would actually make them feel better. And I have found that super helpful with my providers, because they have this sense of safety and security that there is a way for them to actually get help to their patient population. And I'll be happy to discuss more about the policies and procedures when we get to the Q&A section. The next piece is a regulatory framework. During this COVID crisis, as Deb Adler discussed earlier, everything is changing very, very fast. New regulations, new policies, new requirements are being published, if not daily, weekly at least. So try as best as you can to keep track of them to ensure financial sustainability of your practice and maximize the reimbursement rates. As I said, they provided us with some great examples, but those are just a few examples, and they tend to be different state by state. So understand what your state is doing and leverage that to ensure financial sustainability, okay? Which brings us right into the next point, which is parity versus non-parity. For those of you, can we go back? Thank you. For those of you who do not know, the term parity refers to getting paid the same rates for in-office or telemedicine services. So figure out if your state is offering parity or not, and figure out how is that going to impact your financial situation, right? Some states have, and some insurance companies, this is being done at the payer level, they have declared that they're going to give parity through COVID-19, including behavioral health services. So you might want to do your research and figure out how is that going to play out with your financials. The next piece is a licensure reach, and this is related to the scope of practice that I discussed briefly before. So depending on the type of practitioners you have, is a plan that you're going to have to come up with. One of the things that I want you to consider on this point is that there are patients that are moving around to different states during crisis because they are going to shelter in place with their family members or somewhere else. So one of the things that you need to find out is can I still see them while they're not in the state where I hold an active license? The general rule is that the patient needs to be located in the state where the clinician holds an active license. Some of those requirements have been waived, but they are different state by state. So I encourage you to do your own research and figure out where you stand with that piece. The next bullet point is a liability insurance. As similar to in-person medical practices, telehealth services carry liability and malpractice risk. Some policies include telehealth as a covered service. Some of them do not include it, and you have to actually call and fill out an addendum and maybe pay extra for that piece. So call your insurance carrier and figure out where you stand on that. And while you have them on the phone, ask them if it will cover you seeing patients outside of the state where you hold an active license. The next piece, which is, in my experience, creating a lot of confusion, the HIPAA environment. As we know, it was fairly well regulated before COVID-19, and it's pretty clear we should do as best as we can to ensure privacy and confidentiality of our patients. I mean, that's a very general approach, but that's pretty much what it says. So a couple of weeks ago, the federal government published a statement where they explain how HIPAA is waived right now, and that they won't prosecute anyone who fails to comply with HIPAA during this challenging time. And I want you guys to acknowledge that because it happened, but I want you to understand that as a movement from the government to as a crisis response movement, okay? So what does that mean for my practice? How is that going to impact my practice? Those are the questions that I need you to start answering them. There are a lot of platforms out there that are HIPAA compliant and that are free. So you might want to start looking into some of those versus going the non-HIPAA compliant route. Remember that what you do right now is going to impact the way your practice looks in the near future. And as Deb was saying, it's going to be very hard to go back and just see patients in office all the time, because we're now showing the patients how good telemedicine can be. So you better prepare yourself for a shift in your volume in office and telemedicine and have all of those processes in place. As I said, I'm expecting, and other experts in the field are expecting HIPAA to come back to what it was, maybe with a few modifications, but prevent yourself some major trouble and figure out how you can comply with HIPAA right now, and allow yourself some wiggle room, but always with the goal in mind that you are going to be compliant with HIPAA. And the last piece is the state board position on best practices in clinical scope. Again, depending on the type of license that you hold, you want to make sure that you comply with whatever the state board says. To give you an example, some state boards are not in favor of us prescribing pain medication through telemedicine, and that's a lot of the state boards. So those are just the type of things that I want you to be in the lookout for to prevent yourself from getting into a liability or legal issue. If we move to the next slide really quick, I'm going to talk about the training considerations, and I divided this in three: providers, administrative and staff, and patients. I'm going to go through them fast, so if you have questions during the Q&A, we can go through them. The first piece is setting up for success. As I mentioned before, having a HIPAA compliant is a good HIPAA compliant platform is a great start, but sadly that's not it. The HIPAA compliant technology only accounts for the technology piece, but you still have to operate under a HIPAA compliant environment. So during your training for providers, go through the practice expectations on everything from dress code to room setup to what's in the background to the way they are delivering the services and the way they are engaging with patients. Try and mimic the office setting as much as you can to give the patient a sense of familiarity and prevent patients from getting too much exposure to your own private environment. So as a rule for my providers, for example, I ask them to be in a room by themselves. I tell them exactly what can be and what cannot be in the background. And I instruct them, and we have published guidelines in which they have to follow the same clinical guidelines that they will follow in the office. The diagnostic pathway is always the same. It shouldn't change. You have to adapt maybe some of the pieces, but it should be the same to ensure the same clinical outcome in the end. The second piece is crisis management. I already discussed it briefly, but think about it this way. What do I need to know if it happens, if there's an emergency, what do I need to know about my patient? Well, this is a mobile service, so you need to know where the patient is located for you to be able to send emergency services to that location. So the first question that you ask before starting the assessment is, where are you located right now? And if you can, gather some emergency contact information while you're in that process, so you have a way of letting their family know, or whoever they appoint as an emergency contact, what is happening during the session. What has happened during the session at that point. The regulatory framework from a provider perspective, what do I need to know to make sure I'm not breaking the law? What can I prescribe? What can I prescribe? So it's related to the clinical scope piece. So make sure that given different credentials, this might be different. So make sure you understand them from every different type of provider that you have in the company. The coding piece, during my trainings, I talk to them about coding briefly, and as a general guideline, you can use the same codes that you use for telemedicine, for in-office. You can use them for telemedicine too. That includes group sessions as well. That's a question that I get very often, so you can use them. So obviously, I encourage you to go ask your payer, verify your contracts, and ask them about how is that going to be handled. And then we'll talk about the billing piece in just a second. But the last piece, and you see that underlined, and this has proven to be one of the most effective tools for my program to grow as much as it has grown in the past 3 to 4 weeks, is patient engagement. How do I get patients to stay? That means that we might have to get out of our comfort zone and actually start engaging with patients via phone and get them to explain. We can explain to them how this is going to help them and how we can move on to see them expecting the same quality of services through telemedicine. On the administrative side, my recommendation is identify who's going to be leading the effort. Both also find that out for a clinical perspective, and make sure that person is a person sending out communications and really leading the effort and guiding them through this new process. Protocols, they have to understand how is this going to impact my daily operations. Obviously, how to use the platform. It's very important for administrative and staff members. Anything from scheduling to payment collection, as we mentioned earlier during this webinar, the electronic forms, how am I going to get those to my patients? So if you don't have a platform that gives you that capacity, as ours do, you're going to have to get creative and start using a HIPAA-compliant email or DocuSign or some other platform. Billing practices, what do I need to do to ensure that I'm getting reimbursed properly? Modifiers, place of service, and how is this going to impact my revenue so I can make a projection for the near future. And then again, patient engagement. This falls under everyone, not only one side of the equation. So patients, staff and providers need to know how to properly sell these services and how to get the patient to connect to the session. On the patient side, some sort of marketing or guideline PDF or something that says what to expect from the telemedicine service, access and quality at the top, because you should be able to ensure the same quality of services that you're giving in office. How to use a platform, what do they need to use it? Are they going to need a desktop, a laptop, tablet, cell phone, what are they going to need to be able to engage with us? And questions that we get all the time is pricing and insurance consideration. How is this going to impact our patient population? So think about your self-pay rates. Remember that there's a ton of offerings right now. And every time I Google telemedicine or telepsychiatry, you can see 10 more offerings. So make sure that you are being competitive in that sense, while still kind of getting your ROI into this process. So I think the last piece is the lessons learned, and I'm going to start with giving my lessons, and then I'll give it back to my co-presenters. But if you want to move to the next slide. So these are my MindPaths, and not only mine, everybody's learning at the same time, as we mentioned before. The number one is cross-training. Staff and providers need to be trained on telehealth, even if they aren't actively doing it. That, as I'm sure Jen figured out, it would have been a huge game changer. And I was already halfway through my provider population by the time this happened. So it was an easier transition in my side, and I had all of the protocols already developed in all of the training pieces. But looking into the future, that's one thing that I'm never going to stop doing again. Everyone is going to be cross-trained on everything, so they know how to do it in the event of another crisis. Number two, we implemented daily huddle for crisis works at the executive level and at the clinician level. So people love communication. It keeps the company aligned, and it lets them know where we're going and that we're going there together. Number three, do not be afraid to challenge the status quo. And by that, I'm not saying, I'm saying get creative, innovate, find new and better ways to serve your patient population, which is what everybody had to do during this period. And I'm glad a lot of us are being successful at it, at keeping our patients seen and stable throughout this crisis. Number four, telehealth is safe and effective. There's plenty of research that backs this up. So inform yourself, read about it, and that's the message that you should sell to the patients, to your staff, and to your providers. That's just one of the ways to keep them engaged. And number five, patients are actually willing to engage in new delivery methods. It's all about how we sell those new delivery methods. And the promise and to deliver that promise that we're keeping the same quality and access to care that they had before. So Jen, George, if you guys have any more lessons that you want to share, I'll be happy to hear them. Thank you.
Thank you, Dr. Garza. I just would echo everything you said, and just to expand on a few points. For us, we've learned that we need to have more touch points with our patients to kind of make up for the lack of on-site connection. So that's a really important piece, you know, whether it's kind of making sure that we're doing more follow-up calls if somebody doesn't come into group that night or that morning, making sure once we do an evaluation that we're following up with the patient to make sure they go from an evaluation to engaging in treatment. So we're adding in touch points. On the clinical side for us, we've learned that we really think that smaller groups in a virtual setting is more effective. And for Colmac, we co-lead all of our psychotherapy groups. So we already have an advantage having 2 clinicians that we're trained and practiced in using for group. That's been a really wonderful advantage for us with the move to virtual. One clinician can focus on clinical, the other clinician can focus on managing the patients coming into the group, doing things like, hey, you know, George, don't forget to turn your camera on. So that's how we're learning that. You know, because this is so new for us, and you know, the executive leadership has done a lot to work together to support the field, but the reality is we're not the ones out there doing the work. And so that means we don't have all the answers. So I think another important lesson that we've learned is that we need to hear from our field. And we've created a new best practices meeting that is an open invitation to all of our staff. We have to have at least one representative from each of our offices, but it's open to everyone, and it's a place to start talking about things like, okay, so we used to, when a patient came in for an evaluation, walk them around the office, introduce them to the team. That was part of that warm handoff and connection. What is the virtual equivalent of that? And so we're having lots of those conversations. And so I think for us, the spirit of discovery is the most important thing. And I love that, you know, Dr. Garza talked about don't be afraid to challenge the status quo, and to remember always that our patients are also really looking to connect, and there's so much more open than I think we initially think. So those are just some added things. And George, did you want to add anything?
Two things to remember. One, remember that this is going to be over, and we are discovering things now that I'd like to be able to remember when we go back, because we're not going to go back to the same world. Hopefully, the kind of restrictions that interfered with telehealth before that are temporarily relaxed are not going to be put back in full force. So we're going to be able to do this when we go back. We're going to be not 100% in person. We're going to be doing telehealth, and there are just some wonderful opportunities that we're learning. As I mentioned before, we can now start our withdrawal management late in the day. Last week we had 4 people present on a Friday afternoon, and ordinarily we would have said, okay, see you next Monday, at which point only half of them would have showed up. We were able actually to start treatment of 3 of them, and we all could manage them through the weekend, because in the old days, even if we started somebody early on Monday, the weekend was a really problem time, and now we have IOP on Saturday and can manage people. So remember that this is going to end. The other remember I would say is remember to stay cautious. When this all began a month ago, we were quite cautious, and I was so excited to find out and to discover how effective this was that I started to expand a little too quickly. And in my world, that meant taking on people who I didn't think I could take on initially. And I can, in fact, expand from my initial group, but I have to be careful about being overly enthusiastic, and remember that we cannot do everything that we did in the old days. So those are my 2 lessons learned.
one last recommendation for the group, and I've learned this throughout the years. When you're seeing patients one-on-one through telemedicine, your eyes should be looking at the camera and not at the screen. So you can really, the patient can really feel that you're looking at them in the eyes, even if you're not looking at anything because you're just staring at the camera. But that's how we mimic eye contact with the patients.
Well, thank you, panelists. That was so helpful. I really appreciate it. We want to go to a few questions from our that we're hearing from our chat sessions. One is, what has been? I hear a lot about the consumer reaction. I know I heard Jen say that patients were grateful that you were open, right, and still there for business. But what about the provider reaction? I know in my personal experience pre-COVID, it was easier to get the consumers to adapt and adopt sometimes than the providers, but I'm curious about your experience. I'll start with Diego. Oops, I think you might be on mute.
Okay, I'm unmuted now. So yeah, I do believe that statement is true. There's more resistance from the provider side than there is from the consumer side, from the patient side of things. I mean, there's resistance on both ends of the spectrum, but that's why it's important to have your training protocols, everything set in paper, so they know exactly what they're going to be doing, and they know that they have something to fall back into if they need to. So that's my job, convince people that telemedicine is a good and safe avenue to deliver healthcare services. So it's a learned skill. We are dealing with providers providers have been practicing for 40 years, and providers are very new to the healthcare system. So how do you find a middle point to be able to engage everyone in accepting telemedicine as a new way of delivering services?
Jen, any tips on helping providers adopt? Will they all, do you think they'll all partake, or will you have some that will decide this isn't their cup of tea?
I mean, I think at Colmac, the majority of the staff members that signed up to come and work for us did so with the experience of really loving working with people on site and connecting with them. And we talked a lot about the kind of intuitive responses to sitting with somebody. In this, you can't see that my knee's tapping out of anxiety, for example, or that you probably hear if my pen were moving. But those kinds of things, the staff and especially clinicians were really concerned and worried about. I think the underlying constantly coming back to that message of what is the alternative? If we don't move forward with this, what's the alternative for our patients? They are not going to have anyone. So that was really a driving force. But I think, to just jump on Dr. Garza's point, is training is so important. Now for us, we collectively, all 250 of us, joined hands and jumped into the deep end of the virtual pool. But while that was happening, we started doing these. I started holding trainings with all 200 and however many staff members at Colmac, recognizing that we also needed smaller training opportunities for the staff members and clinicians who weren't as tech savvy. So we offered both open all staff, here's my agenda, I'm training you on these features. And then I started to add in these smaller, intimate, where I could talk to people, they could ask their questions, I could turn over hosting control so that they could try the things that I was talking about. Those training sessions, and I held them in the morning, in the afternoon, and at 9 o'clock at night, so that whatever their schedules were, because we also have part-time staff who have full-time jobs elsewhere and then come and facilitate groups for us at night. So I needed to have late night offerings as well. That really, really helped reduce a lot of the anxiety for the staff.
And I had a few comments from my angle, because all my staff are nurses, and the message I would say is be aware of the differences between your different staff. So, for example, some were more comfortable with this than others, and as a supervisor, I had to decide how much to press, how much to be supportive, how much to back off. And for example, the fact that we could now do treatment at all kinds of hours raised issues about self-care and limits. So I had some of my nurses, for example, if we decided to begin, we had to decide how late to start withdrawal. And I found that if we began as late as 5 or 6 o'clock, that meant my nurse was up who began work at 2 and was supposed to be off at 8, was up at 10 and 11 o'clock with an unstable patient, which she could do one night, but night after night, I was in verge of burning her out. Other staff were very clear in saying, I'm glad to work hard during the week, but I need my weekend off. So what do you do about the patients who are now available for weekend management? And that all takes adjustment. So for right now, I am managing the gap until I can figure out what our volume is going to be and how many staff we'll bring on. But I have to watch out for my own needs too. So variability. And the other thing is that people who were uncomfortable at the beginning are now getting more comfortable now. So it's an evolving process. So it's a lot of moving parts.
Great.
George,
Yeah.
thank you. Deb, I just wanted to be sure that you were seeing the questions in the chat. There's several of them that have come in, and I'm sure you'll get to them, unless you want me to read them out for you.
Well, if you want to read one, I haven't seen a lot in the chat.
Sure. Jen, I guess you were referring to blood and urine screens and that you were figuring out how people are doing them. What have you been able to do so far? How are you handling those?
Yeah, it's a great question, and it's probably outside of those first 24 hours, one of the things that has given me the greatest challenge from an operations perspective, because for our patients, doing urine screens, besides being an important lab or medical test, is also a really great preventive measure for people to not go back to drinking or using. Over the last 21 years that I've been working in the field, I can't tell you how many people I've heard say, oh, I thought I was going to have a urine screen. I really wanted to drink, so I didn't because I knew I was going to have a urine screen. So it's really important. And so what we've done is we've created kind of a combination of on-site and at home. So we contract with an outside company that does all of our urine screens. They're completely separate from Colmac. They provided with full protective equipment and gear, one staff member for all of our sites to come in and do on-site blood draws and urine testing for any patients who were willing and wanted to come to our site. So they have all of these protective protocols that they have in place for that, and protective gear and notifications. And then we also opted to do at-home oral fluid swabs, which are observed and done during actually one of our group hours. At the start of our group hour, patients who opted for that option do that actually in front of the group. So those are the two ways, and it's very new for us. And so we're still kind of working through some of those details, but that's where we landed with that.
Great, thank you. And Jen, while we have you, a couple of people are asking why you picked Zoom as the platform. Was there a particular reason?
Yeah, let me answer that one, because that was really my decision. We had, before we went into groups, we had we've actually been using telehealth for about 4 years. And when we were doing individual, we had a different company. But when we made the decision to go to groups, which was actually about 2 years ago, even though we didn't implement it till now, Zoom was the one that we were recommended because they were HIPAA compliant and their technology is very sophisticated, and specifically their ability to have these privacy protections are solid. And so fortunately we had done this a while ago. There were many things we didn't do, like electronic breathalyzing, which would be great if we had that on board. But Zoom has done well, and as Jen said, the kind of Zoom bombing, scary stories you see in the papers have not affected us because we had a already more sophisticated, maybe more expensive licensing that brought in protections that the free version doesn't have.
Right.
And
There
Dr.
is a, oh, go ahead. Go ahead, Nina.
So just speaking about groups, are you also doing 3-hour intensive outpatient groups, or are you only doing the shorter sessions and individual sessions?
No, we're doing we're providing all of our services with the same level of impact. So all of our IOP groups are 3 hours. All of our continuing care groups are 2 hours. Nothing has changed because we really believe that the model works. So we just carried that over in a virtual setting.
Great, thank you.
There's also a question about, will the broader use of telehealth be a threat to provider organizations? Because one thing that is an important component of telehealth is you now can have a statewide reach, right? If you had a single location in a state and now open up virtually, for the most part, you would need to confirm your agreements with your payers and make sure that the level of care is covered. But by and large, if you're offering telehealth outpatient services, one-to-one counseling as an example, or one-to-one psychiatric services, if you're a virtual provider using a HIPAA-secure platform, you can now reach statewide, which can give you a competitive advantage. And I do think, to the remarks about post-COVID, a hybrid model is very attractive, right? To have the ability to sometimes come in person, maybe the first visit, have that flexibility to also, offer virtual services can really reduce your no-show rates. It can have a really big impact on your practice and your reach, if you will. I know we're getting close to time. There was a question about progress notes and kind of threw me back because, documentation is always so important, but has anything changed, Dr. Garza or Jen or Dr. Kolodner, with your organizations as it relates to expectations in documentation? I'll start with Dr. Garza.
So my expectations are always very high. So I don't think that's changed in that regard. But yeah, I do ask them to make sure they are charting and coding appropriately. So they do have to say that it was a telehealth session, and they place the physical location of the patient in every single node that they create, given that this is a mobile service. So that's the main modification when we do telemedicine.
Jen, are you still doing paper? Oh, Dr. George, yeah.
Yeah, we've actually dropped ours because when we owned the medicine, we would chart every dose that the patient was given. And so my nurses at first were spending a lot of time entering every single dose. And I said, you don't have to do that. Just making 2 notes a day, just summarizing would be enough. So that's paradoxical. Ordinarily, I think you'd want to have at least or more documentation.
Great. How are you guys accommodating consumers that don't have internet, smartphones, laptops? They're having challenges connecting? Dr. Garza?
Yeah, we treat a lot of the Medicare population, so they tend to have more, both the Medicare and the Medicaid population tend to be part of the vulnerable populations, which they might not have access to internet. So one of the strategies that we pursue is try to get a family member, as Jen was saying, to help them engage in treatment. If not, we can pursue the phone route, or we have the kiosks installed in all of our 20 locations, so the patient can come to an office under an appropriate environment to protect both my staff and the patient from the virus. But we do have that offering still available for those patients that cannot or do not have access to this type of technology.
Okay. Colmac folks, are you doing anything to accommodate people that don't have virtual audio, video, virtual means?
Yeah, it's been important to us, to echo Dr. Garza, to not discriminate anyone based on lack of technology. And so, the quick summary is that we work really hard. They have direct access to our IT. That was a decision made, that we made very quickly that typically our IT department is available only to the staff members. And we realized we needed to get that information, the contact information, out to all 1,400 of our patients so that they could get help right away. And that has been really useful. And then of course, as I said, we engage family and friends to try to help them out, even, you know, borrowing a phone or tablet. We have been sending tablets to patients' homes so that they can use that. And then always we have the option to use the telephone.
Great. Well, I know we're down to the last few minutes.
On our side, if somebody, the virtual withdrawal at this point management, I would not do that without video. I think that would be a bit more of a stretch.
That's good to hear. That makes sense. Well, I just want to, again, thank all of our speakers. I just have a wealth of experience, some of it gained over the past month, I know, but really terrific to hear your lessons learned and how you've tackled this, and it really sustained your practice quite well. I've heard many practices are seeing 50% drops in utilization, and it sounds like that's not the case at your two organizations. And I think your ability to transition quickly and meet this demand has just been remarkable. So thank you for sharing. I also want to highlight that Open Minds, as we said at the beginning, has a 32-week series. This is the third of the 32. So I would highly recommend that you go out to Open Minds website to look at what is coming down the path for webinars that would help you in this period of crisis management. There's also some resources and links in the slide deck, which will be made available to folks. There will also be a recorded version of this webcast as well. So again, thank you for joining us today, and thank you again, speakers, for your remarks. Appreciate it. Have a good afternoon.
Thank you all. That was wonderful. We appreciate your time. Yeah, we'll send out the slides and a link to the recording shortly.
Perfect. Thank you.
Yeah, thank you all for being with us.
Welcome.
Thank you.
Yeah.